You know, I was struck by the very first question you were asked. Hello, everybody. Which was looking out 4 years, 5 years, what would a fully integrated behavioral health, physical health system look like? And just note that there was an interesting report that was just given to the White House talking about the need for more system-based teaching and learning and training across all of the healthcare professions. So I think this whole notion of what is a system and how does it work is a very relevant conversation and really what you're talking about here. So let me open it up and ask, is there any table who had a really bold vision for what this, optimistic and bold, for what this would look like 5 years from now? All right, let's go. Please. Julie?
All righty. My name is Julie Jones from Hillview Mental Health Center in Los Angeles County. And Alice, you will need to help me. And so part of the bold vision that we had in 5 years for a fully integrated system would include, well, starting with the DHCS waiver, including the prevention and early intervention components from the beginning, and promoting that as far as ideas to change prevention and early intervention for medical care as well as mental health care and substance use disorders, and increasing peer crisis respite options, and having more peer-driven services, as well as targeted treatment for individuals at first break, and also a dialogue around cultural competency in the state to understand the impact of stigma and discrimination in regards to access to care and treatment. Train people away from a one-size-fits-all model, and looking at community behavioral health organizations as well as health plans and county plans, addressing the underserved communities, and also reevaluating consumer choices, individual choices, and then moving away from involuntary care, which seems to alienate people.
And I think when we start to move away from, when we start to move towards a system that's more prevention and early intervention oriented, we don't really need to have involuntary care, because if people are focused on health outcomes in the first place, then why would we end up in ERs? Why would we end up in inpatient cares? So it's a bold focus of learning how to help people focus on health first, not fail first, but health first.
And if we don't, nothing will change in 5 years.
Okay. Let me ask, did any other people talk about cultural competency in relationship to this first question? I'm just curious. Did it come up again? Would you just add what you mentioned in regard to cultural competency? It isn't something we talked about this morning a lot, and yet if we think about the diversity of the state and we think about everybody that now is coming into one plan or another, clearly this cultural competency issue is an issue for the state. Yes?
Yeah, I'm going to give you just a scenario.
Introduce yourself, please.
My name is Susie Matsuda. I'm the Director for Clinical Behavioral Health Services from LA Care. I just want to give you a scenario. We have member who, of course, linguistically, this, barriers, monolingual, and culturally, there's cultural barriers. We're not familiar with the system. But we're talking about folks, refugees and immigrants who have multiple trauma and have a complex medical and physical conditions, and then also behavioral health conditions, and then it's a trauma in itself, and they really resistant and not responsive to no matter the care plan that we so comprehensively offer, but there are barriers, and so they repeatedly, even refuse to go to the hospital, refuse to accept treatment and things like that. So we were thinking about having behavioral health, I love the word health resilience specialist. I just copied from yesterday. Mm-hmm. Love to have that model for behavioral health clinician to intervene. Maybe brief intervention. It's not a behavioral health services, treatment, but brief intervention even before we prior to talking about the care plan, and working through helping and ideally would be a clinician who speak the members' language and familiar with the culture, and also knowing the background, and even help so that they can jump over the hoops, of trauma, of resistance, and then we were talking about the exhaustions of members, having to be told so many times of what they need to do and what can be done for them, all that. So on that care, that we have the intervention before even talking about the care plan, in terms of brief intervention of those barriers.
And the resilience worker is what kind of worker? Was that talked about yesterday?
We're looking at LCSW, MFT, psychologists, folks that can provide a brief interventions to help them work through some of these barriers.
Okay. Anybody else on cultural competency? Yes, please. Here you go. Here you go. Sure.
So we had talked about within 5 years it would be great if we could, instead of always talking about EBPs, evidence-based practices, we could talk about promising practices and culturally and community-defined practices, because we've spent so much MHSA money on identifying community-defined practices, yet we're not at the place yet where we can actually implement that. So we've heard people, we've heard communities that we don't traditionally pay much attention to tell us what they do and what they want. It would be good to actually put that in our system.
Bold visions for what our system would look like 5 years from now. Yes, please.
So that the dollars match the service needs?
There you go.
I think that might be a little bold.
Anybody want to vote on that?
I think it's going to where the client is at, no wrong door, which is part of cultural. I know there's a lot of barriers to actually going out, that you have to stay within your doors to provide the services and get so you can go out to where the homeless are, or that the family resource center, or wherever the client is going. Let's see, and then the community navigators that people have a really hard time just getting into the door. So really addressing the access and having it not necessarily associated with a facility, but with our natural community supports that are out there.
Great. Jerry, do you want to add something? Here you go.
It would be very bold if we had a data sharing system. And we wouldn't have to write notes by hand and send them by fax and stuff like that.
So did anybody talk about tools that are being developed, or anybody developing tools now that make ease of use of this sharing of information across our, anybody doing anything? Yes, please.
I just mentioned that in Santa Cruz County that CANS and ANSA are being instituted to be used across all the different agencies, so that everybody will be on the same page as we're looking at where improvement and transformation and recovery are actually happening, as opposed to chronicity and maintenance. It's the child assessment and needs survey, and then the adult assessment needs survey. And it's an assessment tool which you do at the beginning of service and the end of service. And it's being used in many states across the country now. And it hopefully will be national at some point.
So, a couple of themes there. One is we haven't all agreed on what the right tools are. And once we've gotten agreement on that, then how do we actually share them across various platforms? Yes, please.
Thank you. Bill Walker, Kern County. Building on some of the comments that are being made, towards the end, we started getting into a conversation of technology and where will technology take us, and talking about how both as it leads to the sharing of information, but actually the acquiring of information. And when can clients, individuals, instead of just going to a clinic, be able to use their smartphone and be able to send in their blood pressure and send in information, and then how that communication could be used. There was also a lot of discussion on universal tools being accepted so that information goes in the same way, is shared the same way. But really, I was kind of fascinated where we were going at the end with, where is technology going to give us opportunities to quickly get information that till now sometimes is very hard to get. First off, if a client doesn't show up in your office, hard for them to come in at a certain time, and then how do you get it? As Jerry said, are we faxing it to somebody, et cetera, et cetera. So technology is going to play a huge role.
Yeah, and I would say that there are many technology companies today that are working to address this kind of space. And I think one big question to think about is, again, as we think about systems, how do we take people who have those kinds of design capabilities and technology, help us solve some of the problems we're talking about today? Yes, Sally?
Just what I've heard other tables talk about, and we talked about, I'm just sort of summing up what I've heard, is about peer inclusion. That this sort of integrated system will include peers in all kinds of different roles, in addition to being part of the policy making and decision making. But that's really important.
Great.
My ideal system.
Thank you, Sally. Appreciate that. Over here. Yes.
Yeah, we had some discussion around telemedicine, but also, Karen Stockton, MoDOT County Director, but about telemedicine, telepsych for access. But then we went on to, I think the conclusion I've come to in working with our beneficiaries is that we often underestimate their ability to use their own information and to be engaged by that. And so I've been a part of testing a chronic disease management system that has the behavioral health components as well as primary care. And I think having such a system helps us be proactive, but it also allows the client to have that information, the whole care system to have real-time access to basic information. I don't know how we can do that the work without it and to keep up with the change.
Yeah, I mean, I think you're speaking to a very key component of consumer engagement in general, which is that how do we empower consumers, and particularly consumers we've been talking about yesterday and today, to be able to take their information much more proactively. I love Brad's comment about HIPAA's really a mythical sort of obstacle that we've created in this place, and really giving the information over to patients themselves will help with the navigation of that. Did somebody want to add something else over here on telehealth? Please. Oh, you had something you want to go?
Not on telehealth,
okay,
but
on the system.
That I have a dream that DHCS will match Short Doyle and the Medi-Cal encounter data at the state level and push it down to everybody.
So your solution to the system is that the state would take those databases and combine them?
Yes, and not leave it up to every single county to figure out with every single plan.
Yeah. Can't see your name, please.
Brenda Goldstein, Lifelong Medical Care in Alameda County. I would like to see the carve-out disappear and all three systems of care become one system of care with accountability that's really based on whole health. With protections to make sure that the behavioral health component really gets the resources and that access is available for folks. And that within that system we have a variety of different health homes that people get to choose, not based on their payer source or not based on the severity of their diagnosis per se, but where they want to go for health homes, whether it be a mental health focused health home with primary care embedded, a primary care home with behavioral health embedded, or a substance use home with, and all three things embedded, but with maybe emphasis or expertise that's focused in one way or another that a consumer gets to choose.
Yeah, it's an interesting question. I mean, Toby didn't seem very hopeful about the likelihood of getting rid of all of these carve-outs. But we are talking about 5 years from now, and there are waivers that will be redone between now and then, and there is a lot of interest by CMS to make us look like one state and not have counties look quite different one from the other. So it is a really interesting idea to think about an agenda where the carve-outs would go away. And there.
I think that defining things by severity is really problematic. And on the ground, it really doesn't work very well for providers or for consumers.
So elaborate on that, Brenda. There's a microphone right behind you.
Oh. Thank you. I think that many of us who are trying to implement, in local systems, how people get their care based on the severity of their diagnosis, when we know that that's not how people live their lives or how their illnesses come and go or how their functionality is impacted, just doesn't make sense. It doesn't make sense from a provider perspective in terms of having to use different systems of care and shuttle people back and forth and hope that they could get connected. It really leads to more siloed care instead of integration. And it's not how we think of ourselves as human beings or how we function in the world. Today I'm feeling like this and I'm getting diagnosed as having a serious mental illness, and a year from now maybe it's moderate or mild, and maybe I don't go to that provider or this provider. I mean, it's just it doesn't make sense. It's not logical from how we are as people or how our healthcare system works, and especially with IT systems that don't talk to each other, and with such fragmentation, it just perpetuates, I think, both the stigma as well as the fragmentation of care.
Great. So we've talked, really a bold idea for our system. I wonder, let's take the conversation a little bit to how would dollars flow to support a vision like this from the way it does today? Because obviously these systems are all designed based on how dollars flow. And so did anybody have a conversation about payment reform?
Yes.
Where are you? Please, there you go.
The note I wrote during this conversation at the table was that the healthcare delivery system will change only when payment promotes health rather than profits. That's inevitable. I think a couple of thoughts. My vision is that there will be a consortium of patient-centered health homes, a consortium defined as an accountable care organization, or whatever euphemism you want to use for a system of care from acute to chronic to dental, pharmacy, mental health, primary care, specialty care. But the issue being...
There would be regional, presumably.
Community-based.
Community-based.
Community-based accountable care organizations with a single payer, funding in a capitated way, payment based on outcomes, health outcomes, patient-centered health outcomes. I think 5 years is premature. And I'll tell you why. In my opinion, the focus of healthcare in this country over the next several decades will be focused on the baby boomers getting old. Look at the average age of people in this room. The time for prevention and early intervention is a generation away from us. But the thoughts that we produce here and now, hopefully disseminated into the next generation of leaders, can really refocus the design of healthcare around prevention, early intervention, and not the acute treatment of illness associated with aging.
So,
but it's premature.
So I love your notion that there's better hope in the generation behind us. I'll put myself in your generation. Is there something this generation should be doing in your mind to encourage that generation? I'm going to give you the mic. Encourage that generation to come into this notion of wellness, wholeness. It's an interesting opportunity, and I agree with you from a generation point of view. The future of California is sort of bifurcated, right? We've got a very big aging population, and we've got a very young multi-ethnic population. And I think this question about cultural competency, generationally thinking about how they would have a system be built is a really compelling idea. So just what could we do to help that?
I mean, literally at a very concrete level, listening to Toby earlier this morning, he clearly doesn't see a future with a single payer. He's very invested, it seems to me, in this whole managed care phenomenon, which is only bifurcated rather than integrated healthcare. So I think, I'm going to my own local county, the political will of the leaders who control the taxpayer dollars needs to be influenced. And without the political will, we ain't going to get any change. And how do you train the next generation behind us to either be the political leaders and or to influence the ones that already exist to create the kind of patient-centered outcomes, preventative care that we're talking about? I don't think it's going to happen with carved-out models of care. It's going to happen with accountable care organizations.
Yes.
Yeah, I'm on a slightly different path, but I think it's a pretty exciting day when the head of the Department of Healthcare Services can talk about the potential for a waiver that might include, he actually used the word employment, and he also used the word housing. And so in terms of integration and strategies, we could eliminate the carve-outs around medical and behavioral health and all of that, but to actually think about the other services that make the greatest difference in the lives of people who are complex. We know that we don't engage people who have serious mental illness very successfully unless we start with what they want. And honestly, a lot of the time, it's about a job. It's about a place to live. So I think we should really be rallying around this window of opportunity that Toby has, articulated, and that is one of the first things that we could do that would help us.
Great. Others? Yes. Julie?
I guess another payment reform that we were talking about as it relates to outcomes and change dealt with building a payment mechanism for community organizations or accountable organizations to conduct these outcome measures, in addition to distribution of the information in a timely way, so that way we can change the system to improve the quality of care that consumers are receiving, as well as developing payment incentives that are tied to transformation and recovery goals.
Okay. Yes, please. Right there.
Hi.
Introduce yourself, please. We'll come back. We'll come back.
Hi, I'm Stephen Gronic, clerk of the City of Berkeley. I'll join with Brenda and say that I'm looking forward to eventually.
Make sure that mic is on. I'm not sure it is. Please. Start again.
Okay. Sorry, Stephen Gronic, McClurg, City of Berkeley. I'll join with Brenda in saying that I think to have fully integrated care, we can't have a carved out model. Short of that, I feel like there needs a step in that direction is moving away from the payment system, especially mental health, where you're paid per minute of service. That payment system truly disincentivizes having care based on outcomes or doing services that are based on what the consumer's needs are. And I think I was surprised to hear the panel say they were not thinking at all about that. So that was surprising to me, but I feel like that is an interim step that really needs to occur.
Helpful. Eduardo?
Thank you. One of the things that we discussed here, I think is really essential, is really, again, putting the patient at the center, not just of the care, but of the process, and how important it is for patients or clients to be actively engaged with whatever the care team is. And kind of going back to the cost question, this idea of creating a real cost-driven accountability that includes the patient or the client, where they're making determinations based on their condition in collaboration with providers as to what things are going to help them get to whatever objective they define. So if the objective is being able to get back to work full time, or the objective is lose 20 pounds or lower your blood cholesterol, or whatever that is, those objectives are set with the patient at the center of the discussion, and the process of allocating costs or allocating dollars to whatever's going to help, whether it's a peer coach for exercise or a yoga class or something like that. having that collaboration will help with people being engaged, and thereby people be more activated in their own health condition. So,
yes, Christina.
Hello. We have a great table, and as a result, this is a really innovative idea. Please. But, we're talking a lot about adding layers and layers and layers of additional services or providing more and more support for services. But if you really want to integrate, because when you add more layers and you add more support, what is lost is actual client contact, client care with the physician, for example. So if you want to to compensate for that, maybe you should have groups from substance abuse field, provide groups for medical care with a mental health provider or substance abuse provider and the physician together in the same room. That way there's an incentive for groups of between 4 to 10. Drug medical people know the joke there, so if they're dealing with cardiovascular issues, they're dealing within a group. So the peer is not the support staff, the peer is the client. You can serve more people. They're dealing with the same issues. They can talk about their own process, not the first visit, but subsequent visits, follow-up visits. Come once a month. Come sit in your, your depression / substance abuse group / diabetes group. You can serve more people, save costs, cultural competent.
Kind of a population approach to this. Yeah. Yes.
I want to mention that the state of Oregon has redesigned how the money is flowing from the state to the coordinated care organizations that looks exactly like what people are talking about in this room, what's been said in the last 10 or 15 minutes. And so I would encourage leaders in California to Californiaize the Oregon coordinated care payment model and to adapt it to the state. The second piece, there's two parts of how the money flows. One is from the purchaser to the payer, or the CCO, and the second is from the managed care entity to the provider. And the National Council is going to have a paper coming out in the next couple of weeks that talks about the
National Council on...
the National Council for Community Behavioral Health Care is going to have a paper coming out in a couple of weeks about global payments for health homes and case rates for specialty providers that I think is very relevant. The second part that's relevant to this conversation. And I think those two pieces are really the answer to the question.
Yes.
Sorry.
You had
Hi.
a mic there? Oh, you had a mic. All right. We'll come right back to you.
Oh,
Go
sorry.
ahead.
Does
Go
somebody
ahead.
else?
No, go
Okay.
ahead.
Hi, I'm Lisa Smooze. I'm the Executive Director of Peers in Alameda County. One of the things that I thought was really insightful that this group brought up was it's not enough to keep inventing new additions to a broken system. So, and I know it's been said once before, so it's a wonderful idea to add peer specialists to the system, and we've seen what they can bring to it. But if the system is fundamentally flawed, that isn't going to solve it. It isn't enough to bring another strength-based assessment tool that clinicians are asked to use so that it will change their work. What we need is a fundamental shift in our consciousness and in the way we work. And we need to have the realization that this shift isn't about another tool. It isn't about adding another profession. It's that we are the fundamental transformation in how we work is what's really going to transform the system. We're the intervention.
We're the system.
We are the system, and we are the intervention as well. And so, for example, we know that for people to have the most positive long-term health outcomes, not just behavioral, not just substance use, but health outcomes overall, the most powerful predictor of that is increased feelings of self-efficacy in the client. And we know that self-directed care is a powerful tool to increase measures of self-efficacy. So in any way that we can shift our consciousness from being that sage on the stage to being a guide on the side, that's the fundamental shift that needs to happen. And that's something that doesn't require dollars, it doesn't require legislation, it's something that everyone in this room has the power to begin doing. And I know that we all have our love-hate relationship with HIPAA, and I have a little HIPAA joke real quick. Knock,
Please.
knock.
No, yeah. Who's there?
Can't tell you. Sorry, that was horrible. This is possibly the only room that I could actually tell that joke and get anything other than a huge groan. But I do want to say one of the really positive things about HIPAA, we sometimes forget what it even stands for because we throw around acronyms in this business like nobody's business, right? But it's the Health Insurance Portability and Accountability Act. And the portability piece of it is really important. Because if we can do what we've been talking about and leverage technology to give people the capacity to own their own health information and have that travel with them, like when I was being trained as a clinician, I was over in a law and ethics class. They always hammered into my head of the client owns the privilege, the client owns the privilege. The client owns the information too. That's their life in there. So however we can use technology to shift that power to the client, to that self-directed care, I think that's what's really going to transform our system.
Great. You can't see your name.
Mandy Johnson
Mandy,
with the
please.
Integrated Behavioral Health Project. And Sandra, in response to your question about financing and what that might look like, I guess for me, there's the imperative of now. We have expanded benefits in the Medi-Cal program. We have expanding population. There's money to play with, if you will, to do new things. And right now we have a stable state budget. So we have 5 years to really test ideas and to demonstrate our value to consumers, to the federal government, to the state government, to the state legislature. 5 years we're facing declining ACA dollars, and we very likely, if history proves us right, we'll be moving into the next state budget crisis. Yeah. So I think we kind of have our marching orders to move forward rapidly and not going, oh no, we don't want the future that's got to be 5-10 years down the road. It really is the opportunities for now to improve our systems and demonstrate value.
Great. Okay, we're going to take one more comment in the back of the room, and then we'll wind up this session and move on to our break. How about that, Gale?
We're going to have lunch.
Lunch. Better yet. Please.
Molly Bracelet, the California Mental Health Directors Association, soon to merge with our sister association, the County Alcohol and Drug Program Administrators. Just to sort of make one comment of my observations of all of this is, I think we've talked a lot about some of the public policy opportunities, and I know I work on public policy, so we focus a lot on the weeds, so to speak, of different financing models and payment mechanisms for all of this, and I think that those are valid discussions, and there's a lot of opportunity there. But one thing that struck me recently in working closely with health plan partners and others with the implementation of the new benefits on the managed care side is healthcare is local. So much of healthcare is local, and I think regardless of the public policies that we develop, and there's clearly more work that we need to do there, in the end, relationship building at the local level is just so incredibly critical. And in the discussions that I've had and witnessed over the last several months, where things are working really well, it's where people know each other's names and go out to coffee together and have critical relationships at the local level that they can talk about care coordination in a way that you can't do if you don't even have the name of the person at your local health plan to talk about a client with. So I just wanted to put that out there, that I think all these public policy issues are certainly valid and there's a lot of work to be done, but just key relationship building and how we support local relationship building is something that's going to be so critical. So I think this forum is obviously a great place to start that work.
Great, thank you. Bobby, anything you want to add before we wrap up this session? Well, let me just say that no one said that the system should look like what it does today, right? That wasn't the nature of the question, but it is also true that inevitably when we begin to roll out carve-outs and roll them in, there's always the status quo advocates who'd rather have it that way as long as possible. Ride the fee-for-service horse for as long as you possibly can and avoid capitation. But the conversation here today really did go, I think, in a very bold direction and sort of really put our patients at the center of this, take a very harm reduction model to what is it, what are the problems that they're prioritizing, giving them the information and the tools to do that, and then really leveraging this notion of technology and what it can do for us. If we're not looking in that space and thinking about who those partners are, we're losing an incredible opportunity to connect with people who could really help us build technological tools to address many of these things. So thank you for letting me learn and listen this morning and for the conversation, and I'll give it back over to Karen.